So important point here is when you map it like this, this is the size of the mass lesion increasing and this is the ICP. Okay, so mass will be keeping on increasing, but the ICP will still maintain only. But when the mass is so high, then this goes for sudden increase. Okay, this is no important curve that is related to types of herniation. So subfalcine herniation, uncal herniation, they'll give you pupillary abnormalities in the question. So pick up that point and write directly as uncal herniation. Cerebellar tonsillar herniation is only very important. This is known as Cushing's triad. Okay, in Cushing's triad, what happens when the cerebellar tonsil herniates? It goes and compresses the brainstem. So brainstem will be going in the center, and the cerebellar tonsil will start to compress. So what happens? The brainstem or the main centers for cardiac and respiratory activity. So there will be bradycardia, reduction in heart rate, but there will be hypertension. Bradycardia leads to hypertension, and there will be irregular respiration. That is due to the respiratory center involvement. Okay, bradycardia, hypertension, irregular respiration. This is an important MCQ. And how do you calculate the cerebral perfusion pressure? The normal CPP is 70 to 100, and CPP is calculated by using the formula mean arterial pressure minus intracranial pressure. So what is mean arterial pressure? It is diastolic pressure plus 1/3 of pulse pressure. PP is pulse pressure. Okay, this is mean arterial pressure. MAP is diastolic pressure plus 1/3 of the pulse pressure. Then ICP, how can you monitor? Is by putting a small catheter into the lumbar canal and to monitor the intracranial pressure. So normal cerebral blood flow, this has been asked in your exams. It is 50 ml per minute for every 100 gram of brain tissue. When the level falls below 20, then only there is ischemia. Okay, when the level falls below 20, then only there is ischemia of the brain tissue. Now coming to the most important topic of today's is Glasgow coma scale. Every year, every time NEET-PG, INI-CET, one question has been repeatedly asked in your exams. Please don't get confused and don't make silly mistakes in these. Okay. First is there is a EVM. The maximum score here is 4. This is 5. This is 6. The least score that is possible is 3/15. Maximum score is 15/15. Okay. There is no zero at all here. So there is spontaneous eye movement. That is 4. Then to verbal stimulus, you call his name, he opens his eye. That is 3. On painful stimulus, eye opening is 2. 1 is no eye opening. Be very clear in this. 5 is normal speech. 4 is confused speech. He will be telling some words and sentences also. But he will say, now I am in the hospital, no, I am in the home. There will be some confused speech. Then 3 is inappropriate words. He will start using bad words, abuse you. Okay, that is inappropriate words. Then incomprehensible sounds is just oo. Those kinds of sounds will be considered as incomprehensible sounds. 1 is no speech. And when the patient is intubated, you cannot test them. Okay, don't write as no speech. It is always NT has to be mentioned. NT means you are not at all testing. So not testable. Okay, if the patient is intubated, he will not be able to speak properly. So write it as non-testable. Then 6 is motor response. 6 is normal movement. 5 is when you do pain here, he will be able to localize that this site is paining. Then 4 is now you are creating a stimulus here, he will withdraw. Thus mild flexion will be there. That is known as mild flexion response. When there is abnormal flexion like this, already the patient is keeping the arms like this. This is known as abnormal flexion. Then 2 is abnormal extension. The patient is completely like this, abnormally extended. Then 1 is no movement. And once again, repeatedly I am telling, if the patient is on ventilator, what will they do? They would have put a paralyzing agent. The patient will be sleeping. Then there also you don't test it. There also you mention non-testable. Here also you can mention non-testable. But if only mild sedation is there, eye can be opened. So if the eye opening is present, you can write it. But motor response, if the patient is sedated and paralyzed, there will be no motor response at all. Okay, then also write NT. Then latest they have added is GCS P score based on the pupillary reactivity. So if one pupil is non-reactive, you should -1. Okay, if both are non-reactive, you should -2 from the final score. For example, if it is 11/15, if they give it as one pupil is non-reactive, just -1 and write it down as 10/15. Okay, GCS is very very important, and they will give you two response. One is they will say right side he is able to localize the pain, and left side there is flexion. So which one will you choose? Always choose the better response. Localizing pain is the better response, so consider that as the higher response. And see this point, minor head injury. Even though GCS is 15, no loss of consciousness, it is known as minor head injury. This is one important take home message. 14 or 15 with LOC, it is mild. 9 to 13, it is moderate. So always remember GCS less than 9, that is from 8, it is a severe head injury, always intubate. Even though patient is conscious anything, if the GCS is from 8 and below, always intubate. Then extradural hematoma. This is an image based question every time, either GCS or EDH or SDH. Based on these three, one question is a sure shot question. So don't make mistakes in these type of questions. Why? Because this will be answered by all the candidates. So if you make a silly mistake in these kind of questions, you will be taken out of the competition. Okay, so basic questions everyone should get it right. And medium questions, what you can do, you can get it right for getting a higher rank. But most difficult questions no one is going to answer, so don't waste your time on those difficult questions which you don't know completely. We have to minus from the original score. Yes, GCSP you have to minus from the final score that has been calculated. Okay, this is the take home message. When you go for the exam, be confident. All simple basic questions. Don't make silly errors. So silly errors will make you fall out of the competition, because the competition is increasing year by year. So these kind of questions you should be very very sure and get these answers very 100% right. So EDH is fracture to the thin squamous part of the temporal bone, that is known as the pterion. So vessel that is involved is middle meningeal artery, that is the important vessel that is getting involved. Okay, it is always the arterial bleed. So there will be transient loss of consciousness, and again the patient will become normal. This is known as lucid interval. Okay. Okay, this is known as lucid interval. Lucid interval is characteristic only of a extradural hematoma. Then what happens after then the hematoma keeps on increasing, the brain parenchyma starts to get compressed, there is herniation. So there will be contralateral hemiparesis, reduced consciousness and ipsilateral pupillary dilatation. This always means it is an uncal herniation. So ipsilaterally pupil get dilated and contralateral hemiparesis is there. So this is secondary brain injury now. Okay, primary brain injury is just the trauma which has led to the bleed, but secondary is now uncal herniation has happened and there is secondary brain injury. Okay, so what you should do is you have to do a immediate CT scan of all these patients and find out this lentiform or biconvex shaped lesion. Okay, this is known as a extradural hematoma. Okay, and this extradural hematoma will be fixed to the suture lines, because this is outside the dura mater. Okay, dura mater and skull, between that space will be the hematoma. So it will not pass beyond the suture lines. So indications for craniotomy. Not all patients need craniotomy. So craniotomy, when do you do is the volume is more than 30 cc. Okay, and the thickness is more than 1.5 centimeters here. and midline shift. Here you can see the midline shift that is happening. So normally midline will be present here. Here the midline has been shifted to the other side. That should be more than 5 millimeters. And if the patient is having focal neurological deficits, you should always go for a craniotomy, not conservatively manage them. Because you again augment the secondary brain injury and again the patient will deteriorate. So when the patient comes to you in ER, he might be present in this lucid interval. So never find out that patient is now normal and discharge the patient home. So always some kind of loss of consciousness, some kind of vomiting, some kind of seizure, some kind of focal neurological deficit experienced in the trauma site has to be taken into history and noted down. Then subdural hematoma. And one more point I wanted to mention, indications for CT scan la, if it is more than one episode of vomiting only. But seizure, even single episode is considered. But for vomiting, it should be more than one episode of vomiting. Okay. Next, coming to subdural hematoma. This subdural hematoma, it happens either due to acute injury or a chronic injury also. Okay. Acute injury is mostly due to high energy injuries. Sudden RTA, high collision injuries can go for acute subdural hematoma. Okay. Chronic is due to cerebral atrophy. And this is mostly due to a venous bleed. We saw EDH was an arterial bleed. This is a venous bleed. And the vein that is involved is the cortical bridging veins. What is cortical bridging vein? From the meninges, there will be veins going into the skull. Those are known as the emissary veins or the cortical bridging veins. So when these vessels get torn apart, there will be increased bleeding. So always find out the patient in history, they will say it as a 70-year-old male had a sudden small fall in the bathroom or restroom 1 week back. Now also has a history of anticoagulation intake and now presenting with a fall in GCS. What is your diagnosis? If they tell you it is chronic SDH. Either way, if they tell you in the question has a high collision accident that happens and you have this CT finding, then you always think about a acute subdural hematoma. Here it is a concavo-convex lesion. It is not biconvex, it is a concavo-convex lesion. And after some days, what happens? Liquefaction of the clot starts to take place after 7 to 10 days. Here also there is indications for creating a burr hole, that is put a hole and drain this clot. So when do you do that is when the thickness is 1 centimeters. Here it was 1.5, here it is 1 centimeter. Asymmetry of the pupils. Then midline shift again and GCS drop more than 2 points. So at the time of admission, if it is 11/15 and within some time the GCS suddenly drops to 8, 7, then the patient is deteriorating. You have to put a burr hole, evacuate the clot and reduce the edema. Okay, this should be the take home message. And for example, you don't, some questions have been asked like this. There is no CT scan in your hospital, but you are a surgeon there. How will you find out which side you have to put the burr hole, this side or this side? It is always ipsilateral to the site of pupillary dilatation. Okay, whichever side, if the left side pupil is dilated, put the hole on the left side. If the right side pupil is dilated, put the hole on the right side. So this is a life-saving procedure. That is why I am telling you this. But unfortunate condition, both the pupils are dilated. What will you do? The site of first side which gets pupillary dilatation. First dilated pupil. Or if you don't know that also, put the hole on the dominant. So for right side individuals, it is always the left side dominant. So you try to put a burr hole here. So the dominant hemisphere at least gets saved. Okay. Put the burr hole on the dominant side. Next, pneumothorax. This update, please remember, pneumothorax is a very, very important topic. So there is something known as spontaneous pneumothorax or a traumatic pneumothorax. Traumatic is the most common. Okay, spontaneous happens when there is a bleb in the pulmonary parenchyma which can spontaneously rupture and leading to pneumothorax. But trauma is some blunt trauma to the chest wall causing a traumatic pneumothorax. So air is in the pleural cavity, reduced breath sounds because the pleural cavity is completely filled up with air, the lung is completely collapsed, the breath sounds will be absent. So when you do percussion, it will be hyper resonant and fall in SpO2. Okay, if all these symptoms present with unstable vitals and a mediastinal shift, you can see here, this is known as a tension pneumothorax. Even trachea is deviated here and mediastinum also pushed to the opposite side, and you can see the hyperinflate, that is the lung is completely collapsed and air is within the pleural cavity. Here you should not wait for putting a x-ray or anything, directly you should put a needle decompression. Adults, remember, fifth intercostal space mid axillary line, adults is axillary line, children mid clavicular line. Okay, second intercostal space in the mid clavicular line, put a needle. Just you decompress, you relieve the vitals, completely stabilize them, then finally you put the ICD. ICD is intercostal drain tube. And you have to remember this triangle of safety. This was asked as a NEET-PG question. What are the boundaries of the safety triangle? One is medially is the pectoralis major muscle here. Laterally is the latissimus dorsi, also known as the mid-axillary line that is present here. And inferiorly it is the line drawn along the nipple, that is the fifth intercostal space. This triangle is an avascular plane. So you can do dissection, you can put the chest tube without damaging any vital structures. And one more question they will ask you, one rib, second rib and third rib. Where will you put the chest tube? So it is always on the upper border of the lower rib. Okay, you should not put it here, because if you put the tube here you will damage these vessels. Intercostal vessels and intercostal nerves go along the lower border of the rib. Okay, so if you put on the lower border you will damage this and cause torrential bleeding. Okay, always on the upper border of the lower rib. So two ribs இப்படி இருக்குனா, put it on the upper border of the lower rib, not here. Okay, this is the dictum and this is the procedure to be done. Next, another important X-ray finding, air under diaphragm. Repeatedly asked image based question. Air under diaphragm is just this black color thing that is present here on both the domes of the diaphragm. So for example, if you get an X-ray with air under diaphragm only on the left side, you should always rule out a normal fundus air shadow. Even if I stand and take an X-ray, I will be having a fundal air shadow. That is physiological. You should have air under diaphragm on the right side to be more diagnostic of a hollow viscous perforation. That is known as intestinal perforation. And for how long does it take? So you perform a laparoscopic procedure or a laparotomy and you take an X-ray after 5 days. That some amount of air will be present. You should not think that it has a case of perforation. It is the air that has been insufflated into the peritoneal cavity. It will take about 8 to 10 days for the gas to get completely absorbed after any laparotomy. Okay. Then post-operative period, we already told you. Then peritonitis, if it happens due to gas-forming organisms, there can be air under diaphragm. One false positive is known as Chilaiditi syndrome. This you should remember. Chilaiditi syndrome is nothing but the transverse colon will be present here. And if this is massively dilated, what happens is it will come above the liver. So you can see the air that is present in the transverse colon, it will mimic as air under diaphragm. But it is the bowel air, not the extra intestinal air. Okay. So it is a case of obstruction, not a case of perforation in these cases. So always if you confirm it as air under diaphragm, confirm it as a case of hollow viscous injury, you should go for laparotomy only. Immediate laparotomy has to be performed. No point in wasting the time. It will again augment the peritonitis features. Okay. Now another X-ray finding is bowel obstruction. These are also repeatedly asked in your exams. So, and one more point I wanted to mention is, in case of perforation, you have to make the patient sit or stand at least for 1 or 2 minutes before you take this X-ray, because this 1 or 2 minutes time is necessary for the air to rise up and come below the diaphragm. If you make the patient stand, immediately take the X-ray, and if you miss out that finding, you are only damaging the patient. Okay, so always wait for 1 or 2 minutes so that the air gets raised, then you perform this X-ray so that you can pick these findings. Then bowel obstruction. So in bowel obstruction, there are two views. One is erect abdomen, other one is for supine abdomen. So lying down and erect also. So in erect, you will be able to identify the multiple air fluid levels. So the air fluid level should be more than equal to 3 to confirm it as a case of bowel obstruction. So normal air fluid level is, one is the fundal air shadow, other is in the ileocecal junction. These two should be present in all the individuals. So you should not consider it as a case of obstruction. It should be more than 3. Here you can see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So it is a case of bowel obstruction. And you should identify whether it is a small bowel or a large bowel. Okay. In supine, you can just find the dilated bowel loops so that you can measure the amount of dilatation that has happened. For small bowel, it is less than 3, more than 3, and large bowel, it is more than 5 centimeters. How to differentiate a small bowel from a large bowel is, in small bowel, especially in jejunum, you have valvulae conniventes. So valvulae conniventes will be present along the full thickness or full circumference of the bowel. Okay, but in large bowel, what happens? It is known as hastrations, which will be present only in a partial thickness, only partial circumference of the bowel. And small bowel central abdomen, large bowel lateral wall of the abdomen. Okay, and ileum, you mention it as featureless bowel. Here you can see the valvulae conniventes. So it is a jejunal obstruction. Next, chest injuries. Chest injury, again coming where we started with pneumothorax, now continuation. So chest injury, hemothorax. What is hemothorax? Blood in the pleural cavity. Here also you should, how will the patient present to you with? There will be respiratory distress. You can see the trachea shifted to the opposite side, pushed to the opposite side. And this side, air entry will be absent. And there percussion, it was hyperresonant. Here it is filled with blood. So it will be dull on percussion. So dull on percussion. Immediately you have to put a ICD. Same in the safety of triangle. After insertion of ICD, you should note these three findings. If the volume is initially itself more than 1500 ml of blood comes, or if the volume is every hour, there is a 200 ml output for every hour, or if there is a massive air leak. Massive air leak is the term used when there is continuous air bubbling. Okay, so there is a tracheal injury, there is a bronchial injury on that side. So what happens? Whatever air you inspire will come out through this tube. So whatever air you are inspiring coming out. So continuously the ICD bag will be bubbling, bubbling, bubbling. Then you should think of a massive air leak. So where you should always go for a thoracotomy. And they have asked you which is the best thoracotomy incision in emergency conditions. It is always left anterolateral thoracotomy. Okay, left anterolateral thoracotomy. If you want to extend, you can extend to the opposite side, that is known as clamshell thoracotomy. Just like a shell, it will open up, the entire thorax will be opened up like this, that is known as clamshell thoracotomy. So flail chest, there are multiple definitions in different books. Okay, only Bailey says it is fracture of 3 or more ribs. Okay, this is only given in Bailey. Fracture of 3 or more ribs in 2 or more places. All other books only mention 2 or more ribs in 2 or more places. Okay, for exam purpose, I will try to say that please follow the definition given in Bailey. It is air entry. Okay, air entry will be absent. Okay, so Bailey, please follow this more than 3 ribs in 2 or more places. So what happens? There will be paradoxical respiration. Remember this term. They'll give you an exam as paradoxical respiration. What does this mean? So during inspiration, all the ribs will go out, but the fractured rib alone will go inside. And during expiration, all other ribs will go inside. This alone will come out. So that is known as paradoxical respiration. So what is the treatment for this flail chest is? You always give adequate respiratory. So indication, that is what I told you. All these three are indications. Okay. This was asked in your exams. Volumes and numbers would have been changed and different options. And it should be the adjacent ribs only, not it should be continuous ribs. Okay. Wow. So rib 1, 2, 3. Okay. This portion, and this portion. This entire segment will become a flail segment. It should be a continuous rib, not first rib, fourth rib, sixth rib. Okay. It should be continuous ribs. And here it should be first always maintain the respiration and SpO2. Okay. Then adequate analgesia should be the treatment. There will be very, very severe pain. If it is extended, it is known as clamshell. Okay. So the pain is very, very severe in such patients. So what you should do is you should give adequate analgesia. So put an epidural catheter. That is known as epidural analgesia. Continuously infusion of epidural drugs so that the pain gets reduced. And you have to give them adequate bed rest. Okay. Note insertion of ICD, those are not all essential. Only when the flail segment has an associated pneumothorax or a hemothorax, you can put an ICD. Otherwise, ICD insertion not necessary. And they will also give you an option as strapping of the chest wall. That should not be done. Okay. Strapping of chest wall not be done. Because what happens when you tighten the chest wall again, respiration gets compromised, so SpO2 again falls. So just adequate rest and pain is more than enough. And they'll ask you what is the site of bleeding, source of bleeding in hemothorax. What is the vessel that is involved? The vessels involved are intercostal vessels or internal mammary artery. If you have space below, you can write it down. I forgot to mention that. Okay. Bleeding is intercostal artery or the internal mammary artery. That is the source of bleeding. It is not the pulmonary artery or the bronchial artery. Okay. And another condition known as the pericardial tamponade. So patient will give a history of Beck's triad. So Beck's triad means hypotension. Okay. Increased JVP. Neck veins get dilated. And muffled heart sounds. All these three together constitute a condition known as the pericardial tamponade. So initially what they used to do was in pericardial tamponade under ultrasound guidance, a catheter will be inserted into the pericardium and the blood will be drained. Okay, but now the guidelines have been changed in your latest edition. Please remember. So in penetrating injuries, always go for a thoracotomy or sternotomy. There is no role for needle pericardiocentesis. This needle pericardiocentesis was done previously. Now they have changed it to be doing a sternotomy or a thoracotomy. Why? Because there is an active bleeding. Once you put a catheter, the whatever blood that has come will come out. But again there will be ongoing bleeding. So you should go for a thoracotomy and suture the hole that has been created in the myocardium. These are all very, very essential points. All the points that in Bailey I have put it up here. Next, liver trauma. Now coming to the abdominal injuries. So liver trauma, most common organ injury in penetrating injury is always liver. And if they mention blunt trauma, go for spleen. Okay. Seat belt injury, they tell you choose mesentery. Seat belt injury, most commonly mesentery. Blunt trauma, always spleen only. So take home message, please remember liver trauma, spleen trauma. First investigation is always E first. Okay. First investigation for any abdominal trauma, it is always E first, extended first. Okay. If the patient is unstable, go for laparotomy. If the patient is stable, do CT scan, grade the injury, and choose whether the patient needs surgery or not. Just a simple protocol. Patient comes to the ER, put a E first. Find out whether there is hemoperitoneum or not. Unstable, directly go for laparotomy. If it is unstable, do a CT scan, you grade the type of injury and then decide whether conservative or surgical management is necessary. So operative management for liver, 4P is very important. So you can add pressure, bar, push. Both are same. Just applying pressure can stop the bleeding. This is known as Pringle's maneuver. So if the liver is bleeding here, okay, you have to identify whether the bleed is from the portal vein or hepatic artery or the hepatic vein. So if you apply Pringle's maneuver, what happens? You will occlude the hepatic artery and portal vein. If the bleeding stops, you can identify that this is the source of bleeding. But if the bleeding is keeping on going, it is from the hepatic vein, because hepatic vein is coming from the IVC behind. You are not clamping the hepatic vein in this procedure. Okay. Plugging is just plugging those defects. These defects will be plugged with gel foam. Okay. Then packing is using what to say, mops. Surgical mop will be placed in all the spaces of around the liver, that is known as packing. So hepatic artery, if it is bleeding, you can ligate the vessel. No need to save the vessel. You can ligate hepatic artery, no problem. The liver will not go for necrosis. But portal vein, please remember, it has always to be repaired. If it is hepatic vein injury, then a major surgery has to be performed. Okay. And previously they used to place omentum. So in the very small defects, they used to place the omentum like this, but it has not been recommended. And closed drain. Don't just leave the abdomen open. You close the abdomen and just put a drain on the either flank, this side or this side. Okay, closed drainage is always preferred, because if you leave it open, yeah, if the patient is also unstable, E first. E first is the basic investigation in all cases of blunt trauma. E first will just take 5 minutes. Till you put the IV line, all those things, you will complete the E first itself. Okay. So E first is a basic procedure that has to be done in all blunt trauma cases. Then coming to zones of the retroperitoneum, I'll just give a rough idea about which zone what to be done. Okay, just remember this and go for the exam. They will not go do very deeply into those things. So zone 1 is the central zone that includes the IVC and aorta. That is zone 1. Okay. Zone 2 is kidneys, ureter. And zone 3 is pelvis. So for what type of injury, what should be done? Central zone na IVC aorta. So always has to be explored. You cannot leave it off. Always has to be explored. Zone 2 is periphery. So kidney is involved. So retroperitoneum only. Sometimes it can be conservatively managed. But what needs to be surgically managed is it is a pulsatile or a expanding hematoma. So when you see it as a expanding hematoma, pulsatile hematoma, then you have to go for surgical exploration. Zone 3, it is always from the pelvis, only conservative management. You need not open the abdomen. Pelvis is a closed structure. So from the bone, if it is bleeding, it will settle down by itself, because it is a closed organ. Even if it is bleeding, it will form a clot and it will cause a tamponade effect. If you open the abdomen, that tamponade effect is lost. Okay. Zone 3, always conservative management. Okay. All stable cases undergo CECT whole abdomen and pelvis, and there is some procedure known as angioembolization. So pelvis there are two types of bleeding. One is a venous bleed. So venous is the most common. So venous bleeding, it is always conservative only. But if it is an arterial bleed, it can be conservatively managed. But even after that, if the patient is deteriorating, you do something known as angioembolization. So angioembolization can be given a trial. So identify the site of bleeder and you just embolize that vessel. It will stop bleeding. And two important points in trauma cases, please remember, they'll ask you first airway management or C-spine management. First always C-spine management only. Okay. AIMS people, they ask this question repeatedly. When a patient comes to you in ER with a very severe head injury, the patient is unconscious. What is the first step in the management? Right? C-spine stabilization, not airway. Okay, C-spine. And you should always rule out C-spine injury before mobilizing the neck. So always keep the patient in strict immobilization and put a collar or a spinal trolley. Okay. And one more thing, pelvic fracture to rule out, you always put a pelvic binder also. Until you prove that there is no pelvic fracture, a pelvic binder will be applied and a cervical collar also has to be applied. These two are very, very important. And they will give you primary survey, secondary survey, which they have asked multiple questions. CT scan never done in primary survey. Only one X-ray that is done in primary survey is a C-spine X-ray and a chest X-ray AP view. PA view cannot be done in trauma patients. Please remember, always the patient will be lying down only. You take the X-ray from antero-posterior axis, not from postero-anterior axis. So chest X-ray AP view and C-spine X-ray can be done in primary survey. No other X-ray, no other chest CT scan will be done in primary survey. All these are important points. Chest X-ray AP view only can be done in trauma patients. For PA view to be done, the patient should sit or should stand. That is not at all possible in trauma patients. Then zones in the neck, just like retroperitoneum, I will cover the important topics that you should remember. Zone 1 na கீழ இருந்து, always go from below here. Zone 1 is from the thoracic inlet to the cricoid cartilage. Okay. Zone 2 is from the cricoid cartilage to the angle of mandible. This is zone 2. And zone 3 is above this. So angle of mandible to the skull base. That is zone 3. So out of this, you can identify that zone 2 is the easily accessible site. Okay. So if the patient is stable or unstable, you can directly shift for exploration. No need to do a CT angiogram. If there is a bleeding from the zone 2, you need not put a CT angiogram. Directly take to the OT table, anesthetize him, and you can do a exploration and suture that vessel. But if it is zone 1 or zone 3, you cannot find out those vessels because zone 3 is very, very high up here. You will not be exposed them adequately. Sometimes after anesthesia, what can happen? The vessel can be pulled upwards and even you will not be able to find out the bleeder at all. So in those cases, you have to do a CT angiogram neck and here also CT angiogram neck. And if possible, go for angioembolization only, not go for surgical exploration. For 1 and 3. And even if this fails, then only surgery. But zone 2 directly for exploration can be done. Okay, these are the questions that are related to trauma. Now we're going into breast Phyllodes tumor. So our lunch break will be from after 1:15. I'll repeat it at the end, okay, because now a little bit running short of time. I don't want to miss the important topics. So I'll repeat at the end, Karishma. Don't worry. So coming to the Phyllodes tumor. The Phyllodes tumor is mostly a benign condition. Okay, Phyllodes tumor is always benign. Only based on the size and degree of mitosis. Mitosis can be done especially when you after you take a biopsy. Okay, when you take a small true cut biopsy, the degree of mitosis can be found out. If it is less than 5 per high power field, it is benign. Then 5 to 10 and more than 10 per high power field. Okay, they will give a very, very classical presentation. The entire breast is enlarged, the mass is occupying the entire breast, big lesion, and bosselated. Bosselated means it will be having grooves in between. up, down like that. It will be bosulated appearance, and you can see the dilated veins that are present. Okay, and the overlying skin will undergo stretch necrosis and even can cause ulcerations also, because the mass is enlarging, the skin will start to stretch and there can be ulcer formation. So always in breast, please remember, it is always the triple assessment only: clinical examination followed by radiology followed by histopathology. This is the order that has to be followed. So true cut biopsy and a mammogram will be done. So treatment for Phyllodes tumor is just a simple mastectomy. Simple mastectomy means breast and nipple areolar complex. Only that has to be removed. It is breast plus nipple areolar complex. So when you are planning for MRM, it should be a malignant case. That is known as modified radical mastectomy. Okay, that is modified radical mastectomy only in confirmed malignancy cases. So Phyllodes tumor is this. So one more point in Phyllodes tumor is they can give you the histopathological finding. That is a pathology based question. There will be a leaf like architecture, and there will be both stromal component as well as epithelial component. Please just remember this point alone. Stromal component as well as epithelial component will be present in the histopathological finding. Next, coming to this mammogram BIRAD staging. This BIRADS is a very important topic again. Okay, so you just remember this dictum: less than 40 years, go for an ultrasound; more than 40 years, mammogram. Okay, and MRI will be done only for high risk individuals like BRCA mutation carriers. Okay, so mammogram BIRADS. So if they gave us report as radiologist will give BIRADS 0, BIRADS 1, BIRADS 2. So you should interpret and you should know what to do further. So BIRADS 0 is incomplete assessment. So BIRADS full form I'll tell you. It is breast imaging reporting and data system. Similarly, we have for prostate as PIRADS, for liver as LIRADS, LIRADS, prostate PIRADS. But for NEET-PG, only BIRADS will be asked as a question. So incomplete means now whatever investigation you have done is incomplete for the radiologist to give the complete assessment. So you should do further imaging. So now you have done ultrasound or a mammogram. Now go for MRI. That is known as further imaging is needed. Then one is negative. Here continue the annual follow-up. 2 is benign. Here also routine annual screening. So they'll ask you what is the age group at which the normal female should undergo breast screening is from the age of 40 years. Annual mammogram. Okay. Then 3 is probably benign. That is less than 2% only chance of malignancy. So these percentages are very important. This was asked as an exam question. So less than 2% there is chance of malignancy. Here you should go for a short term follow up, that is 6 monthly follow up. Till now it was annual, now it is 6 monthly follow up. Then 4 is you divide into 4A, 4B and 4C. Only the percentage is very essential here. 2 to 10, 10 to 50, 50 to 95 percentage. Okay. Here you should consider biopsy. Consider biopsy, not biopsy is must. Based on the patient symptoms and size, you consider biopsy. Then 6 is highly suggestive of malignancy. Biopsy is 100% must. Next, 6 is already a biopsy proven malignancy. So initially outside the patient has come with a biopsy proven malignancy. Now you are performing a mammogram. They will give you as a left side biopsy proven malignancy BIRAD 6 to look for the opposite breast. Now you have done a mammogram. Okay, here you should go for treatment. Treatment means either chemo or surgery, whichever the patient needs based on the tumor staging is very important. Here you can see minute, small calcifications here. And one question that was asked in your exam is which type of calcification has the highest risk? That is clustered microcalcification. Okay, clustered microcalcification has the highest risk, not diffuse microcal. And popcorn is fibroadenoma. This can be asked as an image based question in radiology. There are some other teacup, lead pipe. Those have not been asked in your exams. Just revise it before you go for the exam alone. Then male breast cancer. Male breast cancer, only points that can be asked in the exam. I have put it down here. One is Klinefelter syndrome. The point you should take home, remember, is gynecomastia is not a risk factor. This is the important point you should never forget out of this entire box. Gynecomastia is not a risk factor for breast cancer. So BRCA2, not BRCA1. What is the thing you are asking, Anisha? This is highest risk or poor prognosis means for microcalcification. It is the highest risk of malignancy, not poor prognosis. Calcification has nothing to do with prognosis. Only when the mammogram finding shows it as clustered microcal, which means it is more prone for malignancy, then you have to take a biopsy. Then elderly patients and radiation are the risk factors. So again, investigation, again go for triple assessment only. And management is one important point you should remember is prognosis is same from male breast CA presents with T3 stage and a female also T3. The prognosis is always same. Stage to stage, the prognosis is same. It is not that males have a bad prognosis, females have a good prognosis, doesn't matter. It is the indeed T3, here also T3, the prognosis is same. And MRM, BCS is very rare in males. Why? Because the breast fat in males are very less. So if the tumor is around 2 to 3 centimeters itself, what happens? It will involve the pectoralis major muscle. So always you have to go for MRM and removal of the muscle also together. Removal of pectoralis major muscle. And these are always ER/PR positive. More than 80 percentage of male breast cancers are ER positive. So you can give tamoxifen. Okay. Now coming to another important topic, Poland syndrome. This is an high yielding image based question. Okay. Poland syndrome is nothing but unilateral absence of costal head of pectoralis major muscle. Okay. Pectoralis major has two heads. One is the sternal head and another is the costal head. So unilaterally there will be absence of costal head of the pectoralis major muscle, absence of pectoralis minor. This can be either present or absent. Okay. This is not always, but write it as plus or minus. Then aplasia of the second to fifth costal cartilage. You can see the costal cartilage is absent here. And the nipple areolar complex is also having aplasia. There is no breast, no development, there is no nipple. Then alopecia will be present. And brachysyndactyly. Brachysyndactyly means all the fingers will be shortened in length and they will be adherent to each other. Shortened and adherent. That is known as brachysyndactyly. The length of the fingers will be short and they will be clumped to each other, that is attached to each other. So this Poland syndrome is a very important question. You have to remember these 5 points. So before going to that another topic, I'll just cover this alone. This is in case of males, you give tamoxifen. Just write it down here. In females, you divide into premenopausal and postmenopausal. Okay. So in premenopausal, you give SCRM, that is tamoxifen. In postmenopausal, you give aromatase inhibitors, that is anastrozole, letrozole. Why? Because in postmenopausal, the only source of estrogen is the peripheral conversion from the fat to estrogen. But in premenopausal, it is the ovaries that is functioning. So you ablate the ovaries in premenopausal. You in postmenopausal, you give aromatase inhibitors. And what is the treatment guidelines is you have to give for a minimum of 5 years. Up to 10 years it can be given. Okay, just remember in mind, tamoxifen side effect is endometrial hyperplasia and DVT, deep venous thrombosis. And aromatase inhibitors, they cause bone destruction causing osteoporosis. Just remember, no need to take it down. Then last topic before we have a short 5 minutes break is nipple retraction. So nipple retraction is also an image based question. Just remember these points. Physiologically, it can be present up to puberty, that is totally normal. Okay. Pathological is there are two types of retraction. One is slit type, other is circumferential. Slit type is seen in periductal mastitis. And circumferential, always think only about malignancy, malignancy, malignancy. Here, this is an example of a slit-like nipple retraction that is occurring due to the periductal mastitis. The nipple discharges also repeatedly asked MCQs. Serous discharge, they will give you an example as a 30-year-old female coming with a physiological small 1 drop, 2 drop per day from a nipple. It is always physiological only. Okay, you should reassure them, no need for any further investigations. Only when the output is very high or some other lump is palpable, then you have to investigate. Otherwise, it is physiological and just reassurance will be the answer. In pregnancy, you have, and even in ductectasia, you can have serous discharge. But which is most specific to ductasia is greenish. Okay, greenish is most specific to ductectasia. And blood in nipple discharge, remember easily, is single duct. Now think about only intraductal papilloma. If it is multiple duct, always CA, carcinoma, carcinoma. Okay. Then black is periductal mastitis and ectasia also it can be present. Milkish discharge, galactosile, normal lactation, and remember prolactinoma in the pituitary gland. Okay, and one more treatment method alone I will mention. If it's intraductal papilloma for single duct, the procedure is known as microdocectomy. If it is multiple ducts, it is known as Hadfield's procedure. Okay, remember this alone. Microdocectomy is for single duct and multiple duct it is Hadfield's procedure. So we'll have a small 4 to 5 minutes break and then I will take up to 75. Okay, then we'll have a lunch break from 1:15 to 1:45. Okay, small 3 to 4 minutes alone.